Like people are still streaming in. Again, thank you. Welcome to this week's edition, Mount Pacific Quality Health, It's Worth a Shot, our weekly 30-minute webinars. This week, we'll be discussing its state immunization information system reminders, just a couple highlights and reminders for those of you to be mindful of. And we have a very special guest today that will be covering two common pharmacy citations and how to avoid those. My name is Jessie Kinsey. I'm a registered nurse and account manager with Mountain Pacific. Next slide, please. Just a few updates. We will have another NHSN data entry training session coming up Monday, April 10th. And we just dropped that registration link into the chat box for you. We're going to be taking a look at that flu reporting requirement that will be affecting nursing homes, and that deadline is coming up quick here in May to make sure you have that annual reporting in. We'll be covering that data entry process. Again, that's April 10th. Registration link is in the chat. Feel free to sign up. Next slide, please. As always, just a few housekeeping items. Feel free to add your webinar topics or clinician ideas into chat, and we'll continue to meet every Wednesday. We do have a polling question this week. It's a 4-part polling question. So the first part, does your facility have a process in place for your short stay residents for post-discharge follow-ups? Hopefully everyone is seeing those polling questions. Miranda, can you see those on your side?
I can see them.
You can, Dave? Okay.
Yep.
We'll give you guys just a few moments to answer. Just looking at that discharge process, transitions of care, and trying to get a temperature check on needs and barriers. So if you take a few moments to respond, that would be fantastic.
Yeah, it looks like
Thanks, Kathy. Okay, so if you say no, okay. It exempts you from the rest. Okay, thanks, Kathy. We'll get one more person to respond. That'd be great. Then we'll end that poll. Thank you, guys. We can close that polling question out. All right, thank you. We're working on some transitions of care resources and educational opportunities, so this is very helpful. All right, next slide, please. All right, as always, just a quick peek at the weekly influenza rates across the country. We've seen that downward trend and really low prevalence across the United States as far as influenza surveillance. However, continue to be mindful of your backyard. There is still some transmission activity in a few of our states. New York and DC have continued to have high influenza transmission activity. So spring breakers, just something to be mindful of. And then New Mexico actually did go a little bit down in transmission, so as well as California. So just something to be aware of. All right, next slide, please. Our weekly COVID-19 snapshot, cases are on the decline, deaths are on the decline, hospitalizations, still that steady trending, and vaccination rates for the updated COVID-19 bivalent booster, staying steady right around 16.5% of our population. So still time to get that updated vaccine and stay up to date with your vaccinations. Next slide, please. Community COVID-19 community levels, similar to the flu, just a reminder to be aware of those transmission levels in your neighborhood. We're seeing some outbreak activity in Alaska, Hawaii, big portion of Montana, and Wyoming there. So again, just being aware, as a lot of folks traveling, moving moving around for spring break. We still have, even though activity is on the decline nationwide, we still have some high community transmission levels in our areas. All right, next slide, please. So with that, I just have a few reminders for folks about the state immunization information system reminders systems. And just trying to get my screen set there. All right, next slide, please, Mary. So again, these IIS systems, these are state specific. There is no federal platform at this time. These are state specific platforms. And really the reminder is that as we look towards the future to manage COVID-19 vaccinations, as those vaccines look to go commercial, that there's really a value importance in utilizing your state's IIS system. If you're not already enrolled, go ahead and shoot me a message, email me, and I'll drop my email into the chat box, and I can connect you with the resources with your state. These systems, again, really, they help to provide consolidated immunization histories, and they also help to aggregate data so that you can look at vaccine surveillance and program operations, barriers, public health goals, trending, all for a specific region. So there's a lot of value and multi-purpose use within the IIS systems. And some of you that may be in a state that recently expanded their platform might be aware of this. So Alaska just updated their IIS system to include a public-facing application where you can get on and as someone in the general public can assess and look at their vaccine needs. And I've heard of a couple other states that aren't too far behind in getting that public-facing app too. Next slide, please.
A question in chat. The question is, are employees still considered up to date with the initial series, or do they need to have a recent bivalent booster?
There's some timing that comes into consideration as far as how long it's been since they've received their primary series or their last booster, and if they would be eligible for the bivalent. And I'd be happy to whomever is asking that question, if you want to message me, I'd be happy to help sort that out for you. Thanks, Miranda. All right, next slide, please. So as we look at those immunization information systems, again, state specific, it really helps to support, when you utilize these systems, timely administration of vaccines, helps support those clinical decisions, again, data exchange, and these are free services to enroll in when you utilize this program. And I know that Montana has some upcoming training dates to use MTRACs. And again, if anyone's interested or not enrolled yet, please reach out to me and I can assist you to connect with your state partner enrolling. And as a nursing home provider, I know that having access to these systems has been incredibly valuable so that you can check residents' immunization status real time and not necessarily have to wait on paperwork or the paper shuffle. You can take a look at what they may be due for, or again, what their current status is on, maybe even COVID-19 vaccinations and if they're up to date. Super helpful for new admissions as well as discharges. Next slide, please. So with that, again, feel free to reach out to me if I can be of assistance. It was just a quick reminder, if you're not utilizing your state immunization information system, now is a great time to enroll. So now I want to introduce our guest speaker, David Lawless. He is a clinical manager and pharmacy consultant for Omnicare, and he actually oversees long-term care clinical pharmacy support for 6 different states. and he'll be reviewing the 2 most common pharmacy citations and how to avoid them. Thanks for being here, Dave.
Hey, thanks, Jesse. Appreciate it. And thanks, everyone, for joining today. I know we don't have a lot of time together, but I do love to open it up and let you know that the chat function works. If you have a comment or a question or an observation, feel free to throw it in the chat box. Best way to learn is learn together. And what I'm going to talk about is not so much the ones that I see very commonly, because we've worked really hard with our facilities on these issues to prevent them from happening, but some of the most common things that I see. And one of them, so having prefaced that, we're going to talk about a couple of the most common things. One of them is storage, and one of them has to do with psychotropic meds. And you can go ahead and go to the next slide, please. And feel free to throw anything in the chat, even if it's where you're coming from. So what are some of the two of the most common things? Well, a lot of labeling and storage issues, and then unnecessary drugs and psychotropic medications. Usually when I hire a new consultant and start training them, and I'm actually training a new person right now in Colorado, one of the things that I focus, primarily on is the psychotropic rules, and make sure that they have all of those down very well, because if they can get the psychotropic stuff down and understand that very well, that's probably about 80% of the citations that you'll see in long-term care is all about psychotropic management and making sure that we're using meds appropriately. But storage is a very common one. And a lot of times, when I have a facility going to survey, the minute they walk in, I ask them to call me and just let me know that they're in survey. And the next thing that comes out of my mouth is, go check your insulins. Because I don't know what it is about insulins, but a lot of people have problems understanding that they have to label the insulin as of the opening date, and then you have to label it as in like what the expiration date is. And let's throw out just a quick question, see if anybody knows, like, let's say you have a Levemir on your cart. Does anybody know what the expiration date is once you open the Levemir? Can you go ahead and flip to the next slide, please? Vicky Davis says 28 days. 28, everybody's throwing in 28 days. Good. So actually, no, it's not 28 days. Levemir is actually 42 days. And I asked that because it's kind of a tricky one, but here's the thing, like, there's so many difference in variations of when insulins expire that that's why I recommend that you put the expiration date on the vial, because everybody thinks it's 28 days for all of the insulins, and it's actually not. So when an insulin is kept in the fridge and it hasn't been opened yet, it doesn't expire until the manufacturer's expiration date that's on the vial or the box. So generally that can be up to a year, it depends, but as long as it's kept refrigerated and not opened, it's the manufacturer's expiration date. As soon as you open that vial or pen, whether you keep it on the cart or in the fridge makes no difference. It's going to expire around, the same time based on the manufacturer's guidance. And several of them are 28, some of them are 30, some of them are 42. There's a whole variety of things. So you got to do one of two things. Either you date it the date that you opened it, as well as when it expires, or you have a chart somewhere, maybe on the cart, maybe in the med room, where if you have the opening date and a surveyor is asking the person that's on the cart looking at the insulin, doesn't have the expiration date, and they say, when does that expire? Then they know that they're supposed to go check that chart and let them know the correct date that it's supposed to expire. I find it a lot easier to just go ahead and label the expiration date. And most of the time what ends up happening is when you're in survey and there's a lot of stress going on, generally they forget that there's the chart and they say 28 days. If the answer isn't correct at 28 days, then you get a citation. And insulins can really rise to the level of a high-level citation very quickly, especially if they've had some erratic blood sugars. Then they figure that that's our fault and we're not storing it correctly. So so labeling, that's the big thing is labeling, making sure that it's labeled when it's opened, or actually just documenting when it's opened and then the expiration date. Does expiration depend on vial versus pen? No, it actually does not. It's based on the product. And I would encourage you, if you have a consultant pharmacist, touch base with your consultant pharmacist, ask them for a chart that has all of them on there. We actually have a storage document that we give to our customers, and it has all the expiration dates based on if they're in the fridge, if they're not in the fridge, if they're open, not open, so on and so forth. So definitely encourage you to get a that document so you can refer to those. Storage things on here. You do have to have the Schedule 2s separate, and obviously you have to have those inventoried. Pretty common thing to have those actually not behind a double lock, which I don't know why that is, but always have to have controlled substances behind a double lock. Let's go to the next slide. So we put in some really easy examples here. So based on observation, interview, and facility policy review, is the term facility failed to ensure all drugs and biologicals used in the facility were labeled in accordance with professional standards, including expiration dates and with appropriate accessory and cautionary instructions. So really, I mean, it can depend on what they find, and how much they find is gonna determine your level. So I've actually seen one insulin vial that wasn't dated and as of opening date, and that particular resident had some erratic blood sugars, and they gave him an IJ. So depending on the surrounding situation, it can really elevate the concern. So like let's take kind of back to what we were mentioning before. If you have a policy in place and the policy is that you date them as of dating, opening, and expiration, and you have the expiration chart, everybody's familiar with it, so on and so forth, and you have one that wasn't labeled, that would be a lot lower level than if you had a couple that weren't labeled and you had no idea when they expire correctly. That would raise to a lot higher level of a citation. So the scope and severity is kind of hard with that. It's based on the potential of causing harm. And even if it's only one insulin, it could have had the chance of affecting a lot more because you didn't have the policy procedure in place. So hopefully that makes sense for everybody. Let's flip to the next slide because we're going to really talk about psych stuff now. So a couple of things that a couple ways that you can avoid what we were just talking about previously. Make sure that it's definitely not a good idea to take meds from home. Make sure that you have a controlled substance policy. Make sure you're storing them correctly. Make sure that your pharmacist is reviewing your controlled substance storage as well as documentation. Obviously, they should be looking for destruction records and all those kinds of different things. Medication carts. Hopefully, your consultant pharmacist is reviewing your storage areas. We do basically like a 10% audit for our customers, and really we're looking to determine if their policy procedure is working. So we're really looking to make sure that they have a process in place for checking for expired meds. But I can tell you out of all of the citations that I see, probably the most frequent one across the country is just simply having expired meds in the cart or in the med room. And generally speaking, what I see is the surveyor will walk into his med room, and they'll open the furthest cupboard in the corner that's on the top shelf, and they'll reach up to the very back shelf and find something that expired in like 2015 because nobody looks in that little section of the cupboard. So always make sure that you're doing a really good review, and remember that even things like iodine pads actually have an expiration date. So you do have to check everything, especially when you're in your window for reviews. Go ahead and go to the next slide. Hopefully, if anybody has any questions, you just pop it in the chat because I'm looking at the chat box. So there's a lot of things that get included with the psychotropic medication documentation, and really that could be, I've done workshops that are like a full day workshop on just this topic. So there's really a lot of information that's in there, but I want to just hit some of the top issues that you need to be aware of when you're looking at psychotropic citations, and also some of the recent changes that happened in 2017. PRNs are a big deal now. PRNs used to be something that we used to be able to do a risk versus benefit letter, and we could get away with that, and we could continue to give them, so on and so forth. Now there's kind of a limiting factor, and the key is 14 days. So a psychotropic medication starts, and let's assume that these psychotropics are not antipsychotics. Your psychotropic medication starts on day one. You have 14 days to review and see if it works and if it's needed. If you need to continue it after the 14 days, the physician can do a risk versus benefit document and say, no, we're going to need this. And that can continue on for a period of time. I've never got anybody to tell me what that period of time actually is, but I recommend that you update that probably monthly if you're going to continue the PRN. Antipsychotics actually, after the 14 days of PRN, the physician is supposed to come in and see the resident again and write a new order. So that's the only way that works. They can't call in and reorder it. It can't be a continual order. It's supposed to DC after 14 days, and then the physician is supposed to come in and review that resident and determine if it's needed, and if it is, then they're supposed to write a new prescription. So PRNs really, I want you to think of PRNs not as, we're going to use them when we need them. A PRN really should be kind of a time where you're reviewing to determine if that medication works and does the resident need it on a continual basis. So after 14 days, really what you should be doing is either saying, no, we manage them fine with non-pharmacological alternatives, and we don't need the medication, or we need to schedule it because it definitely works for that person. Let's flip to the next slide. So what I want you to think about is when you start a medication, whether it be an antipsychotic or an anti-anxiety med or whatever it may be, then you're going to start the medication, you're going to identify a target behavior, you're going to identify what the trigger is for that target behavior, and then to monitor if it's working, you're going to track that behavior on a regular basis, and you're going to track side effects. So basically what you're going to be doing is when that taper is due, and the tapers are twice in the first year, 30 days in between trial, 2 quarters, and then yearly after that, when it's time to review for a taper, what you're basically doing is you're reviewing the efficacy monitoring, which is how many behaviors they're having, and then side effects. And if they're no longer having the behaviors and they're not having side effects, then that can get you in one of two situations. Either they're doing great, or you may need to consider a taper. And what I mean by that is a lot of times somebody can have like an explosive behavior that they're using an antipsychotic medication for, and then they finally get it normalized, and they're not having the behaviors anymore. But over time, they've kind of not participated in activities. They've lost weight. They may have a pressure ulcer, spend most of their day in their room, sleeping a lot, don't carry on conversations, no participation in activities at all. That would be not a situation where you have side effects, but where their function is declined, and that would warrant a taper at that time. So you really couldn't just do a taper letter to say, no, we don't want to taper. You're not really going to get away with that. So when you're monitoring those kinds of things, you want to make sure that you think about functional status as well. And that has to do with not just antipsychotics, but anxieties, antidepressants, all the psychotropic meds. So I have seen several situations where, they're not falling, they're not having side effects from the medication, and the physician said, no, we don't want to taper anymore. And they said, no, you absolutely should have tried a taper. Their function has absolutely declined over medication or over time, and that would definitely be a citation. Go ahead and flip to the next slide. So what are some things that you can do to try and prevent some of these things? Obviously, like I said, to cover this in a few minutes is really difficult, but you want to make sure that you partner with your consultant pharmacist. Hopefully you have a strong consultant pharmacist that understands the rules and the monitoring. You want to make sure that you're monitoring for safety and efficacy of all medications, not just psychotropics, but there's some special considerations when you're talking about psychotropic meds. Make sure you have strong policies, procedures in place. Make sure you're talking about on your QAPI, and obviously make sure that you're educating your staff on what your policies and procedures are, and that they're following those appropriately. So when it comes time to review for taper, you have the good information to put into that monitoring. Go ahead to the next slide. A couple resources there for you. There's lots of different resources out there, obviously, but I'm a huge proponent of working closely with your consultant pharmacist, because that's what we're there for. We're supposed to be the experts to help you in medication issues. So I encourage you to always lean on your consultant pharmacist as well. And final slide. And questions. Does anybody have any questions or any comments on what we covered there?
Hey, Dave, I have a question for you.
Sure.
So what are some good examples or good reasons why we should not allow meds from home, or review that policy as far as accepting medications from home? Why would we not want to accept meds from home?
Well, there's actually a couple different reasons, and I'm going to give you the two most important. One, if you're a skilled nursing setting and you're accepting a Medicare resident, let's say for like hip repair therapy or something, then you get reimbursed based on a certain level of care and all the things. You guys know all the criteria and everything. So one of those things that you're supposed to be paying for is medications. So if the resident brings in their own medications, then that's actually an act of fraud. So you're not supposed to be receiving any medications from home, especially in that situation. But when we go to, say it's a private resident and they want to bring in all their meds, One of the biggest things for pharmacy and pharmacists is that we want to make sure that the meds were stored correctly. So for instance, once you take an insulin out of the fridge, and this is great because we were just talking about insulin. Once you take an insulin out of the fridge, it's no longer the manufacturer's expiration date, and it's clear, like that will degrade and it will not work the same. So let's say that a resident brings in an insulin in a little, refrigerator pack and says, "Oh yeah, this has been refrigerated," but they didn't really tell you that it was actually left out for a week when mom forgot and left it out, and therefore they're bringing this medication in that you can't guarantee the storage. So a lot of it is really just the storage and handling to determine that it still is a safe product to be given. Those are the two most common reasons.
Thanks, Dave.
Yeah.
Oh, Maria has a question.
Let's see. On a unrelated note, if a resident is Med A, does the facility assume the cost of any vaccines they need to get? Those new PCV vaccines are expensive. Jesse, I bet you can answer that.
Yeah, so as part of the Inflation Reduction Act, any vaccines that come up on that ACIP recommendation list for your Med A residents should actually be covered. And I know I have worked through some coding complications or misunderstandings with some vaccines. So Maria, if there's a vaccine like that Prevnar 20, I know has come up, there's some coding things around that on how to get it covered. And I can connect you actually with a couple of vaccine reps to assist with that. Good question.
Good answer. Any other site questions? Or I would also add that allowing patient residents personal medications at the facility also opens up concerns if the medication is actually the correct one. Yeah, that's a great point. And I've actually seen, and I can't even tell you how many issues of diversion I've investigated with theft of controlled substances. And you'd be amazed at how many grandma's pills that are supposed to be oxycodone are not oxycodone. And then they bring them into the facility and they're like, "Oh yeah, this is grandma's oxycodone." And you're like, "Yeah, no, it's not. That's actually an ephedrine that somebody bought from a convenience store."
I was thinking the same thing, Dave. How many times have we
yeah,
opened up bottles and looked like, yeah, that's not it.
Yeah, right. Yeah, exactly. And then you're like, "Has grandma really been taking these?"
Good question, Larissa. Good statement. Any other questions, guys? A great presentation today. Thank you so much for being our guest. Wonderful topics, Dave, and a lot of great information shared forward. Thank you to our audience. If you guys have any questions, feel free to reach out. Otherwise, same place, same time next week. Take care. Be well, everyone.
Thanks, everybody. Have a great day.
Thanks, everyone.